And to moderate our conversation, the CEO of Nexuses, Tash Baharin, will be taking charge of this conversation and directing traffic. So if you have any questions, do raise your hands. She'll be able to point you out. And we also do have roving mics for our moderator. So on that note, Mr. Tash, over to you.
All right. Good afternoon. Okay. So we're just going to start with just like introductions first. So Patrick, sorry. Why don't you go ahead, and introduce yourself.
Thank you, Tash. I am Patrick, CEO of Sarawak AI Center. We started this center a little bit more than 5 months since March this year. You can imagine Sarawak AI Center more or less equivalent to NIO plus R&D. So it's like NIO plus plus for Sarawak AI Center. That's my brief introduction. Thank you.
Hi, thank you for the kind invitation. My name is Julian, and I'm one of the co-founders of CareSense AI. So CareSense AI main purpose is to make healthcare and wellness more abundant for millions of people, because I think we're a team of people who have both tech and healthcare backgrounds. But one thing we did realize, we see is that whenever people, politicians talk about healthcare, it's always about how limited it is, how scarce it is, not enough nurses, not enough doctors. I think AI has the potential to alleviate some of these constraints and do a lot of good if it's done in the right way, and that's what we're trying to pursue.
Hi everyone, Assalamualaikum warahmatullahi wabarakatuh. Salam semangat. My name is Nadiah Abdul. I'm with the Malaysian Rare Disorders Society. I'm also the board member of Rare Disease International. Some of you might be wondering what's rare disease. Basically, rare disease are diseases that rarely happen in society. So if we're talking about the World Health Organization's definition, it is a type of disease that happens in one live birth in every 4,000 live birth and more. So often you might have heard, I'm 1 in a million. So for people living with rare disease, they're more than 1 in maybe 2 million, 1 in maybe 3 million. But what I wanted to share is that collectively, people living with rare disorders are, number one, not contagious. So despite the fact that we say disease, I know coming out of COVID-19, a lot of people have got misconceptions about the word disease. So even if I had a rare disease, which I don't, if I did, I'm not contagious. The panel is safe. Okay, no one's gonna contract anything from me. That's number one. Number two is that collectively we are many. So while the disease is called rare, who can hazard a guess how many people in the world lived with rare disease? I'll get the organizers to give you a merch if you can guess right. Any guesses?
Any takers?
Any takers?
What's the percentage of the population who has rare disease?
Correct.
Yeah.
Is that a hand raise, or you're gonna like scratch your 10 what? 10% of the population? Wow, okay. So in the world, we have approximately 300 million people living with rare diseases. There are over 7,000 different types of rare diseases. We have 300 million people living with rare disease. So Malaysians, it is many times over the population of Malaysia. And if we combine force, we would actually be probably the third largest country after China and India. And if you combine with the total number of people living with undiagnosed diseases or syndrome without a name, it's called SWAN, syndrome without a name, you're talking about 350 million more living with undiagnosed diseases. Why do I want to tell you this? In a world of health, in a world of AI, in a world of advancement, we still have people who are going around with diseases without a name. So 650 million people is not small. And of course, very much with that comes the issue of equity, comes the issue of accessibility, comes the issue of accessibility and availability of breakthroughs. So the Malaysian Rare Disorders Society is a national association that works together with 20 other registered organizations with specific rare diseases. And we look at the rights, the welfare, and of course, the well-being of individuals living with rare diseases in Malaysia, as well as their family. And so we have a national footprint, but we also have a regional and international impact. Thank you.
All right. Very colorful introduction. Thank you. So, Assalamualaikum. My name is Tash. I'm the founder of Nexuses. And essentially what we do is we help you tell your medical story to your doctors. Right? So currently every single doctor, every hospital you go to, you have to retell the story. Well, with us, we just help you tell the story once every time. Okay? So to kick off the panel, I have a list of questions here, mainly talking about opportunities in AI, but I like to actually start with a statement that I'd love to get everyone's thoughts here, which is, it's great that we talk about AI in healthcare, especially now, but currently even in Malaysia, in public settings, public healthcare settings, they are still yet to use the internet. So, you have the internet, you got Web 3.0, which is the blockchain, and then now you have AI. What do you guys think about this? Why are we talking about AI when we're still yet to implement the internet actually in healthcare settings?
Who wants to go first?
I think one thing that could be interesting to note that for various reasons, some healthcare institutions may have an air gap. That's why they don't access the internet sometimes. But chances are most of the staff would have a phone and they will be very connected, right? In fact, they'll be using Instagram, TikTok, Facebook, WhatsApp for sure. And I think during COVID, because I was in a healthcare organization back then as well, we saw how something like WhatsApp leapfrog the adoption, right? Instead of implementing something like Tiger Text, which is like a clinical chat application, everybody is using WhatsApp, from the government down to the hospitals. It unified everyone. And I think that precedent has been set to some extent, but those were also unprecedented times. So the question in my mind is, while we are all connected through our mobile devices, what would a safe and ethical use of AI look like for clinicians, clinical staff, and also for patients?
I think that's very interesting. You talk about safe when you want to innovate, right? So you're talking about not crossing the line. But when you do AI, doing something that you've never done before, are you not meant to cross the line no one has been before, right? So you say WhatsApp leapfrogged in COVID times, right? People are already using it. So why is, let's say, the policy still, you reckon, still lagging behind,
Well, I think it's still very early days for many healthcare systems. And I think unlike WhatsApp, WhatsApp is a person-to-person communication tool. But here, when you talk about AI, it appears to be a bit of a black box, and it depends on what a person puts in. And the inputs also entail personal data, right? It would be a bit odd if I, as a nurse or a doctor, was taking a photo of my patient's wound or symptoms and sending it through my private phone. But I have seen, for example, in the US, there's this tool called Open Evidence. It's a 3 to 4 year old startup that basically is building clinically validated AI that's well evidenced and well referenced. So it's like a ChatGPT bot where it equips the doctors. So the doctors can download Open Evidence, use their medical registration number to sign in, and then they can ask questions. It's like consulting a living textbook, especially because the text is always updated with the newest research and evidence. So they may use it on a personal device, but it's just like a reference cheat sheet for them, right? But that's one way of leveling up their game without putting information in. Yeah, so that's one example of ways that AI can leapfrog, but done and rolled out in a sensible manner.
Yeah, I have a little bit different perspective. In fact, AI is supporting or facilitating health practitioners, like clinicians, doctors, so on, especially when they are practicing in underprivileged area or rural communities. For example, if general practitioner, GP, want to check patients in rural communities for their eye disease, for example. They may not be, they may not have the specialized knowledge in the eye disease, but they definitely can take a picture and send to their the eye specialty ophthalmologist in tertiary hospital and so on. There is one way. But if you with the help of AI, that means AI can running on your phone or on any edge device, where this AI can do an initial screening for that particular patient's eyes and look at this eye disease whether it is something serious or not. If it is not, then it's not urgent to send the patients to hospital in the city area. If yes, then have to send the patient immediately. So these AI are actually kind of agents representing the eye specialists from tertiary hospital, providing advice not to replace anyone to the GP at rural communities. So in this way, AI really help and provide more equitable access for patients, for specialists in the AI form.
So if I may, going back to your question on why are we looking at AI when we still have people with no internet, right? I mean, that was your core question.
No, it's about like, it's about like we have all of this tech, right? But internet is still
Correct.
is still yet to be implemented in a hospital.
Correct.
You know, yeah.
So I'm going to ask everyone, would you stop eating rice just because now you can eat steak? As Asian, it's a very basic question. Everybody's saying no, right? So the point is, as far as internet is concerned, to me, it should not and no longer be in 2025 a luxury. But unfortunately it is, right? It should be a base minimum that every single person living in ASEAN should at least have access to. Why? Because it opens up to everything from communication, tracking, learning, health equity, registration of birth, right? We were just talking about how geography also plays a very big role on internet penetration. So if geography is already such a challenging thing that we need to overcome, what more, talking about AI in health settings? But just because we haven't gotten those right, it does not mean we need to pause on everything else until we get that right before we go into AI. Because I do believe that at the end of the day, it's not a zero-sum game. We have to do both concurrently, and we have to prioritize based on what is necessary for our respective countries, in our respective settings, for our respective need. It's not a silver bullet that's just slapped on for everything. If one country has a national action plan or intervention for AI, it might not necessarily be relevant for the other country because it's a totally different setting, a totally different resource setting, a totally different community. So specifically for health, and I'll draw that on the inference of people living with complex medical needs or rare diseases, right? So then there's a context to this. It generally takes about 4.5 to 5 years to get an accurate diagnosis. The majority of people living with rare diseases are either undiagnosed or wrongly diagnosed, misinformed or misdiagnosed. And in a population of 34.8 million in Malaysia, we've only got 14 geneticists, 17 genetic counselors. It's mind-blowing. The ratio doesn't work at all. So where does AI come into the place, right? In low resource settings where you can, of course, push for the internet, which is a must, right? And I'll give an example of WhatsApp since you spoke about WhatsApp earlier. We also have the opportunity to utilize AI to really catapult things that are there forward. But what we need to do is really look at the guardrails, what are the safeguards, what are the plans in place to ensure that those that are currently marginalized don't end up even more rentan, even more vulnerable than before. So how many people are here from Singapore? We know that Singapore has already implemented, present company excluded, right? We know that we've got Selena, which has been set up in the government hospitals, and this has been expanded into the polyclinics as well, not just in the big hospitals. We also know that AI has been used for chest x-rays to look at tuberculosis in some countries, and how this can actually really speed up that process of trying to circumvent issues of TB, which is back in ASEAN, by the way, we know that. And at the same time, imagine how we can shorten the diagnostic odyssey, something that takes 5 years before you find out. I'll give you a real point, case example. a friend of mine who's a large advocate for rare disease, he took over 8+ years to actually get the right diagnosis. Doctors thought he had cancer. So he went down the gamut of radiotherapy, chemotherapy, everything else that needed to be done. He became blind because it was a progressive condition, only to find out many years after, oops, you actually don't have cancer. The main cause was a rare disease and you had ganglioglioma. By then, how many years of your life had passed, which days pass, you're not going to get back, right? So where there is an opportunity to reduce the margin of error objectively, bridge that gap for those that are really marginalized, utilizing AI, then we should. But that does not mean in any way, shape, or form it should in any way overtake human compassion, values, empathy, understanding of bedside manners between doctors and patients. That's not something AI should ever take over or is able to take over right now. How would you feel if you had a terminally ill prognosis and the AI says, "Thank you for coming to our clinic. Based on the report, you are now going to die in 6 months." How would you feel? Not exactly the best. I'm sure we can lace it in language modelings to say things nicely, right? But that human compassion that needs to be in place, especially in low resource settings, is extremely critical. Now, talking about WhatsApp, since we're talking about lower versions of tech, right? WhatsApp was a real equalizer during COVID-19. Most of you got your updates on the number of deaths, the number of active cases, either through your WhatsApp or everyone who never used the phone before now had a device tracking everything from homework to work meetings, everything through WhatsApp, right? There was a project that we were part of that was called Jiwa Ibu, and it was done smack during the pandemic, and we prototyped it first in Sarawak. And the idea behind that was, how do we reach community health workers, in particular maternal health bidan, like bidan kampung, the community health workers that had to go to the longhouses, help people in far to reach places, on how to assist. Because in this day and age, it is unacceptable to still have women bleed before they reach the hospital because they had a complicated delivery and were unable to reach the clinics fast enough. So Jiwa Ibu was developed as an idea at that point. Of course, it's got a long, long way to go still, to help bring that wealth of knowledge into the hands of community health workers. So while they meet the mothers to make sure that their pregnancies were going okay, that the babies were not breached, they were also able to impart a little bit more of sexual reproductive health knowledge, maternal health input. And that's where we can actually see tech as a real equalizer. We don't have to be worried because at the end of the day, it's a tool. If I were to send all of you into the kitchen and I give you flour, oil, sugar, what else do you want? Flour, oil, sugar, eggs. Okay. I bet you every single one of you will come up with something different. Somebody will bring chokodok, another person will bring cake, one person will boil, another person will fry, right? These are just ingredients. What we make of it depends on our ingenuity and our core values and our understanding of why we're actually doing it. Thank you.
I definitely want to hear from Professor Patrick, because from Sarawak AI Center, you are, if not the man who's going to deploy AI in Sarawak, right? So what are the opportunities that you see, perhaps not only in Sarawak, but in the region, for AI deployment that is in line with the policies?
Yeah, in my opinion, we see AI in two perspectives. One is consumption of AI, another one is production of AI products. AI. So we have to choose a side when we want to identify exactly what to do. If we were to talk about consuming AI products and services, all we need to do is pay to some service provider. I think that is quite straightforward. But of course, if you want to produce or develop some AI product and services and sell outside Malaysia, that will take quite a lot of efforts and have to go through a lot of challenges, so on, like a startup thing. I believe Julian know that very well. So for Sarawak AI Center, it is state fund entity. Our goal here is to build sovereign AI, meaning going to have trusted infrastructure. Second is to be technology independent, which means we have our own talents developing our own products and services in AI. Number 3 is to ensure there are alignment in terms of culture and ethics, which is very important to ensure the data set that we use to train any AI models in our product and services must have our Malaysia cultures, Malaysia ethics and values in the data set. And number 4 is to ensure that Malaysia or Sarawak continue to stay in a strong position despite whatever geopolitical landscape in the world. So with that as a fundamental, then I believe we can support many organizations, including private sectors, to build their AI products and services with peace of mind. Not only funding, I believe businesses, they need a lot more other than funding. Like, you know that very well. Other than funding, they need ecosystem, they need businesses. Maybe the business can start with some government tenders, some government projects, but from there, the startup or the SMB must find a way to fly above the sky. The further, the better, the bigger, the better, so that we can help Malaysia or support Sarawak per se to generate more revenue from outside Malaysia. That will be the pure net income or revenue that we generate for Malaysia economic growth. So that is the main direction of Sarawak AI Center, working with NIO and Ministry of Digital.
All right. So I'm definitely keen on hearing from Julian, right? Because you run a health tech in Singapore, right? Where the policies, the infrastructures are actually ready for this, right? So there are opportunities perhaps for us that we are not ready yet, we just don't have it, that we can't even see it. So for you, what do you see are the opportunities, given the opportunities of Singapore actually, with its infrastructure and policies?
Yeah, thanks for the question, Tash. I think looking at the opportunities without referencing Singapore specifically as a model, because I think everybody starts from a different place and different constraints, different needs, can definitely learn from one another. But when I think about the opportunities more generally, but not tied specifically to Singapore, I think of 3 boxes or 3 buckets. The first one is, and I think about the opportunities specifically to improve healthcare with AI. There are 3 buckets I have in mind. The first one is to make the workflows of existing healthcare systems more efficient, right? Because if you think about amount of people that's involved in any average hospital, right? From the registration, you have a intake card, you have to fill in your personal details. If you go to another clinic within the hospital, you might have to do it another time. And not only does the patient have to put in that information, you probably have a couple of admin staff, right, who are processing this, filing it away, transcribing it into a computer if there's a computer. But I think AI can really do a lot in terms of efficiency, both in the patient interaction at the front desk, but also in the back office. I think the second bucket would be clinical decision support, which ties in very much to what Prof was mentioning, where you can have paramedical or even community health staff equipped, or GPs even, equipped with tools and diagnostics methods that are paired with a specialist. I really like the example that was showcased in the adjacent hall, right, where I think the polyclinics in Malaysia are rolling out AI-driven DRP or diabetic retinopathy screening, right? So that even if you might be a GP in the polyclinic or in the future even an optometrist with a fundus camera, you'll be able to help people who are at risk of vision loss due to diabetes, right? So I think that is one very clear example of clinical decision support. You're not replacing the ophthalmologist, but you're helping to cast the net wider and make sure that fewer people fall through the cracks, right? And the last bucket for me, I think, is where which I feel we've been spending most of our time in R&D is the hyper-personalization. This is, I think, the third and also a very big growing opportunity, even I can imagine for yourself, Tash, where AIs can be used to be an agent for the patient to personalize a lot of the perhaps it could be certain amounts of advice, could be wellness, right, to begin with, and eventually to clinical, right. As a small note, you probably saw the GPT-5 announcement last week, where the company OpenAI is trying to push GPT-5 as ready for healthcare or ready for therapeutic, applications. I think the verdict is still out there, but I think if considering how all the models are progressing in a matter of 24 months on their health benchmarks, I think more and more opportunities will be unlocked for hyper-personalized support for patients, improving patient experience. It could be everything from helping support wellness, like we do. We support, bringing personalized longevity and wellness and preventative care to people through a WhatsApp agent. That's one of the products we've built. But we're not limited to that. We're thinking, how else can we bring this personalization for people so that they can have a better grasp of what it takes to stay healthy and to perhaps improve. So that's some of my thoughts.
Well, I guess you cannot talk about trendy words like longevity, instead of wellness, right? Yeah. So now that we have discussed like the baseline, that it looks like we are actually at the frontier of applying this tech, how would you scale it? What are the challenges you think in scaling? Now we have it. Now the problem is actually how do you make it bigger? How do you get people to adopt it actually? Yeah. Sure.
I think when we're talking about scale, at least from the group that I'm with, I think the main challenge that I see is the issue of inclusivity. And we spoke about this before the panel, right? Let's be real, okay? Let's drop mic and be reals. It's highly unlikely that we're ever going to see equality in AI or equality in tech. So we need to be talking about equity. How do we actually look at some of the gaps that we know are present? If we are going to scale, it's not just about scaling those that have to have more, but instead, how do we look at being that term that says a tide that raises all ships? So how do we be that tide that raises all ships, knowing that each and every one of us are starting at a very different starting point? So when I was contemplating on what to say today, especially in terms of scaling and making sure that everybody has a piece of the pie, I thought maybe there are 5 things that we need to definitely look at, right? Number 1, accessibility by default. Right? When we talk about accessibility by default is often representation for anything that's being created, especially in the space of health, is so inequitable. The few are designing for the many. Do you realize that? Whether it is breakthrough drugs, biologics, therapeutic medicine, machinery, infra, tech, policy, it is always and often the default that the few are actually planning for the many, right? But AI can actually be used as an equalizer for this. So how do we cast that net wider? So when we're talking about accessibility by default, I mean things like multi-language, low bandwidth, screen reader friendability, caregiver consent. And of course, you mentioned that earlier when you were doing that, right? To ensure that values and cultures and nuances and norms are all put in. So with that, first I want to congratulate the ASEAN AI Summit website, because that's one of the few websites that I have seen. If you go to the website, you see that little blue man, that little guy, the little blue man on the website. Click on that and you'll realize that the website was actually developed with accessibility in mind. It included changing font if you're dyslexic. It allows you to change from dark mode to white. Okay, now you're all checking, right? Okay, so ASEAN Summit organizers, I'm giving you a plug. But the idea behind that is it should be by default. Why is it like a special thing that we're having something for ASEAN at this level that only then do we have a conversation? Simple things like, where are our sign language interpreters? Because not everybody who's deaf can read, right? And we're pushing things like Braille, and we're not, 70% of people who are blind in this area don't actually read Braille because they've been using tech. They use audio. And if they are deaf and blind, What does that mean? Right? There are rare diseases. Kindler. Anyone knows Helen Keller? Right? Helen Keller was an amazing advocate who was deaf and blind. So how do you ensure that in a space where kesenjangan, right, the gap is not equitable, how do we ensure that when we talk about scale, we don't scale by just leaving people behind? That's one. Number two, when we talk about accessibility, we always talk about nothing about us without us. Anyone in the PWD space knows this very well. But in a lot of the modeling, the language processing, the data that we're trying to churn for a lot of this tech, it's very much based on either the global north or non-LMIC or low resource settings. So if you're trying to create, using AI, modeling of all of the different reports that are out there to come up with, say, for example, the orphan drug for whatever rare disease that you are trying to solve for. However, you never consulted the people living with rare diseases themselves. You didn't have enough representation from the countries that you were planning to solve for. How do you then come up with a solution that meets their needs when you're solving it elsewhere? And I still see this happening. I'm not saying this because it's theoretical. I'm saying this because it is still happening as we speak. So representation in data centers is extremely crucial, whether it be gender, whether it be age, whether it be geography, whether it be conditions of health, especially for health, is something that is crucial to ensure that whatever it is that you are trying to put out there actually meets the needs of the people that you're trying to solve for. And this I spoke about yesterday, because yesterday I was in a panel on gender, health, and AI. And one of the things that we talked about was, one way of scaling is meet the people where they are. How do you solve for the longhouse talking in Jalan Duta or Mongkiara? You need to be where the people are to understand what their needs are. At least the sampling needs to be there to be able to be brought back to Putrajaya, brought back to Kuala Lumpur, thought about, and then reapplied again. It's a cyclical, in fact, it's like an infinity loop, right? It never ends. Now, when we're talking about the next thing that needs, you've got accessibility, you need representation. The third, and we all know this, is ethics. And ethics here not only talks about payment, it also talks about, what about paying for outcomes instead of paying for outputs? At the moment, a lot of people here, I bet, for personal consumption, would be using GPT non-paid version, correct? And we all know this because even before GPT was there, everybody was busy Googling themselves. Like, I can put my name on and try and figure out what the internet says about me. But as we progress, we also now realize that AI and the internet and everything along with it is a bubble. We are not necessarily becoming closer to each other. We are individuals separated by personal bubbles. Your personal bubble of what the AI is telling you is what you have been feeding it, if it's for personal consumption. So if we're trying to scale, we need to break these bubbles. Because otherwise, we're not bringing people together. We're just a whole bunch of bubbles in a place that's existing simultaneously but not connected. We are a generation that is more exposed and virtually connected than ever before, but never really connected the way we were. So the last point is citizen health records. If we're talking about scaling, we need to talk about what is that governance, check and balance, especially in terms of personal data protection, especially in terms of citizen records. You're talking about imaging, you're talking about omics across borders. For the rare disease space, because procurement is such a heated debate, in ASEAN, we're now talking about, can pool procurement be done? And what would pool procurement look like, not just for orphan drugs, but also for tech? If there is a screening method that works in Vietnam, how can we pull that to Cambodia and to Malaysia in a way that's adaptable, accessible, affordable, available for everybody to use? If we cannot solve these questions, we're not going to be able to scale. You're scaling, but you're scaling in a bubble, in an isolation, right? And the last point I want to talk about, which I think is super important, is transparency and grievance process. Because we always talk about best practice, we always talk about best case scenario, right? But what we need to plan for is, what are the grievance mechanisms if, in the event, AI fails? If it gives that wrong advice that ends up costing lives or costing, beyond finances, your death, I'm guessing, is probably the worst thing that can happen, right? So what transparent grievance process and redresses, not just process, but how do we ensure that when there is a grievance process, that redress is actually equitably met? How many of you have bought a purchase of anything, whether you buy it online, you bought it in person, and you suddenly realize you don't like it, or it's faulty, or it doesn't work, and when you call the helpline, you don't get a response? Either it says, thank you, your call is important to us, there are 375 other calls waiting, and you're waiting in line, right? So how do we use AI then to bridge that gap and ensure that there's actually processes in place, safeguards and rails in place, so that governance and redress is actually available to ensure that boo-boos are actually assisted?
And for you, Julian, like what do you see the scalability here? You know, what are the challenges? This goes to you as well,
Yeah.
Professor Patrick. You know, like
Yeah.
I think
Later,
one
after
of the
Julie.
interesting things about scalability challenges is that in order for it to be rolled out into public services and public health, actually it relies heavily on data integration from like the local precincts all the way to the state level and even to the national level, and that can be quite challenging, I can imagine, not just for any one particular country, but for any large country with varying needs and varying levels of data. But another thing that came out about scalability is, I think, literacy around AI, because to kind of address the issue you pointed out about having your users participate in the design process, the only way for them to really participate and so-called have a seat at the table is to kind of give them the literacy to create their own canvas, to draw, to write, to draw, so to speak, on that canvas. And I wonder how that would take place.
For me, we look at the AI products and services, either it is diagnostic or non-diagnostic. If it is diagnostics, it has to adhere to all the regulatory compliance and so on. For Malaysia, it's MDA, US, FDA, CE, and so on, depending on which country, which region in the world, before anything can be scaled further. If it is non-diagnostics, let's say for example screening without asking anyone to pay, for example, I can give an example of coffee, which is a cough sound AI developed together with Ministry of Health during COVID-19 for every smartphone user to record their own cough sound and send it up to the AI to tell whether they have COVID-19 or not. So that's a particular application I actually made available to everyone on the internet, as long as you just go to the website, record your cough sound on the phone or PC, laptop, whatever, and the AI will tell you whether you're high risk or low risk. Why it is important, exactly about equitability, not equivalability, but equitability, where we noticed a lot of people actually don't have access to rapid test kits. Even though it's like 4 ringgit per test kit, doesn't mean everybody have access to it. So what if they don't have access but they have a smartphone? Can they check whether they actually have a COVID-19 cough or influenza cough? So that kind of accessibility, scalability, we have done it together with Ministry of Health during COVID lockdown. We can see that hundreds of thousands of users are using it for free, and that's it. Once you go to diagnostics too, either it's a software or hardware or physical devices, you have to go through all the regulatory pathway before you can scale anything. Thank you, Tash.
all right. We can do like a bit of Q&A, maybe just 1 or 2 questions if the crowd has any. Who has any question? Oh, all right, perfect.
Yes, good afternoon to a distinguished panel. My name is Joseph. The question which I wish to pose is, can AI determine the efficacy of vaccines especially in situations like upcoming viruses or whatever, whether the relevancy of the vaccine for any patient, can AI be a solution? You know? So in that sense, it saves costs in terms of importing such vaccines, and it's applied only to those who are really in need of it. What's your view with regard to this? Thank you.
Hello, Joseph. Do you mean new vaccine going to the market or vaccine already in the market? Both.
Probably like the COVID, okay, and there's a vaccine is imported, and we don't know the efficacy of the vaccine. Only at a later part we knew. So whether with AI, whether we can determine the efficacy of the vaccines, whether it's really whether it serves its purpose.
Yeah, I'm not a specialist in this area, but this is based on what I understand so far. Yeah, AI can be a tool for anyone to study the efficacy of any drugs or vaccines, provided the data is available. So no data, no AI, as simple as that. If the data of every users are available, actually AI can be used to analyze the efficacy.
Thanks.
All right, I think that is it. That's our time for today. All right, thank you very much, guys, for this session. All right.